Good afternoon. Well, we are hearing about different technologies, but friends, I must tell you, every lens will work, but it will work if the surgeon has complete belief in this system of presbyopic correcting lenses. That means it translates into your body language. And I have seen it among all those who have used this lens and who continue to use it extensively. A multifocal or a presbyopic correcting lens who works for them, who have total belief in, one, the technology working, number two, a strong belief in the neural adaptation that all of us have and we always underestimate. With this, when a patient comes to us, there are several available IOL options where we don't forget even the monofocal or the toric. And finally, of course, is a presbyopic correction can be done with a monovision also. And there are several of them who accidentally or planned do a monovision and it works for them. So talking about presbyopic correcting lenses, all right. Now, although we have covered it in a counseling session, before a patient comes to me, and when I have to decide, what lens I'm going to put, I have to definitely make sure that this patient is ideal. In a sense, I have to look at his personality. I have to look at corneal cylinder that he has. Would he be doing good with a multifocal? His current tolerance to glare is a big indicator in my choosing what type of lens I'm going to put for him among the presbyopic correcting lenses. And of course, his general knowledge, whether he has unilateral or bilateral cataract also helps me decide which multifocal I'm going to use. Obviously, we have had a nice talk on pre-op testing. Those go without saying that unless they give you an approval for a presbyopic correcting lens, you will not go into the next step. Pre-op counseling definitely is an important aspect. The chair time that you spend is going to matter. May still need low power glasses. Post-op is something that you have to convey. Counseling regarding glare and halos goes without saying, is something that has to be mentioned. Counseling regarding bilateral cataract in the close vicinity is an important factor. There are patients who would say, doctor, I do not want to get the other eye done now. Then either you change the type of multifocal you use for them, or you probably put it off for some more time. And of course, when you do it, you should also be talking about the reversalness of this technique. If the patient, in the rare circumstances, is not happy with this, but it normally doesn't happen because we definitely get used to it. Now, which IOL among the presbyopic correcting lenses that I will choose will depend on his needs. His needs for distance, intermediate and near. His profession makes a difference. His recreational activities, like the case that was mentioned in the counseling session. Now that was a patient, who definitely wanted to get rid of his glasses. I said, why? He said, I'm a footballer, I have to play in the night and under the glare, under the floodlight. And obviously we knew that probably he won't be a good. His amount of computer and mobile usage also decides which type of a lens probably would be better for him, because today we have wide variety of presbyopic correcting lenses, from a low ad to normal ad to high ad to, of course, the trifocals and extended depth of vision lenses. There will be some who will want extreme crisp vision for distance, and they're not so particular about near vision, but they still would want to be rid of glasses. Probably they go for another category. I think I have a wrong presentation. Another step that I would really like to concentrate on or look at is a multifocal lens which will use lesser light overall. The distance may or may not be as crisp as monofocal, average intermediate vision and excellent near vision. I'm sorry I gave them and they have put a wrong presentation. It doesn't matter. Another thing that I'll do is before I tell, I would always show them, when I talk of glare and halos, sometimes they don't understand. It's always better to show them the pictorial thing and also tell them that if their needs are something where a low ad is going to be more useful because he has a lot of outdoor activities, probably a low ad would be better than a high ad. There is there's another concept of a blended vision where low power near ad in the dominant eye and a high power in the non-dominant eye would also probably work. So the mix and match is another concept that works. And the new lens that gets added up is the extended depth of vision lens, which combines a diffractive pattern with an achromatic technology and hence much lesser glare and halos as compared to conventional multifocal, because almost has it something like a monofocal, and contrast sensitivity is almost comparable. This is a picture I would always show to my patients before I decide, because when I have three types of lenses, it could be a conventional multifocal, it could be a trifocal, it could be a symphony, but I have to show them to tell them that symphony or the presbyopic lens like an extended depth has contrast or the halos which is almost comparable to a monofocal. No, it's totally a different presentation. Yeah, when a patient comes to me and if I have to finally decide what IOL I'm going to use, if a patient is someone whose needs are, let's say, he has to work on the computers, he has to all the time, he also is very particular about his near needs, or he wants to drive and all that, then I would kind of settle for a trifocal lens with that supposed to, or that is what we all have experienced, that really works well. Someone who just wants to get rid of glasses, whose needs are not so very accurate, but he definitely, like a retired person who wants good reading vision, wants to watch TV well, he probably settles for a multifocal. Someone who wants a good vision, who's very acutely aware of the contrast, and or he says ki I don't want those problems at night, so he would probably go in for, in my practice, extended depth of vision lens, where I tell them, look, this lens will overall give you a good vision, but an occasional need to wear low ads is not ruled out, and probably that lens would work for him. Then of course someone says, doctor, I want to get one eye done today, and for the another eye I want to wait for a while. After explaining to him that, look, you will have to go in for both eyes if you want multifocal, still he doesn't want, I'll be more inclined to put extended depth of vision kind of a lens, but that lens in my experience has really worked well when I do it today and I put off the other eye for some time. And of course the blended vision or the mix and match is something that I will always look at. There are people who in the past have used contact lenses or monovision with spectacles, and they know this concept, so they would probably be good for low ad and high ad as a combination. And of course there are cases where it could be controversial, but if a patient needs an IOL exchange and he still wants to have some presbyopia correct, I mean some near vision, I would be a little more inclined to use extended depth of vision lens in such an eye. But all in all, what I want to say is any biological process is not a perfect one. So I have to explain to him, and I'll definitely do it. But one thing is certain, I'll talk to them about the halos and glare being part of the procedure. But one thing I'll definitely tell them, look, whatever good vision that you get is going to be in the good light. In the evening, your vision is going to have these problems, and the glare problem is something you are definitely going to overcome. And when you're so confident about these things, when you get across to him, they probably would agree. But one thing is certain, that it all depends on what exactly he wants. If he says, Ki, I'm absolutely okay using glasses, probably he is not a candidate for multifocal. But if someone is very keen and he accepts all these drawbacks, I think I have a candidate in whom I can definitely put it, and he should really do well. With this, sorry, I didn't look at that. So patient needs to understand that there's no return to vision of 20s. Visual performance depends on light conditions. Neuroadaptation takes 2 weeks to 2 months, or sometimes more. And there'll always be an impact on quality of vision at night. So this is something that I'll literally, get into their mind, and then of course they are great candidates for multifocal. And in spite of all this, and one thing I have seen, that practically all the lenses work. Some lenses work better, but they just go with what kind of an expectation that patient has. Thank you so much.